All right. Good evening, everyone. I want to thank you guys all for being here. And I'm really kind of excited at what we're going to be talking about because it's kind of a point that comes up for us all the time when we teach the classes and when we review our material and all our findings. It's just like, how do I actually do this? So I want to go into some detail, but right off the bat, I just want to let everybody know that this is an open session, so if you have questions and answers, please use the Q&A. If you have any questions for the Dawson team, please feel free to put that in the chat, and we'll make sure that we address everyone's queries throughout the evening. And if anybody wants to follow up with me afterwards, if something came up later on as they're either reviewing the material or just something that they meant to bring up but didn't get a chance to, then feel free to reach out to me also. I'm always here to try to help. But one of the things that we learned very, very early on in our seminars is that we perform a very comprehensive exam, which usually takes us about 20 minutes from start to finish. And we start seeing some patient problems that we may not have noticed if we were looking at them for a very quick examination that we might have done at a hygiene visit. That information that we see, the photos and our thorough complete examination enables us to see those problems, and then we start coming up with diagnoses as to, what's the etiology of those conditions. And then we go into our treatment planning phase and say, all right, if we see signs of instability and we do realize that we need to treat this condition that the patient has, we can come up with some plans. And so we're going to talk about some of those plans today. And so let's go further. In all of what I'm going to show you today and anything that you'll ever hear me talk about, I don't take shortcuts. Dr. Dawson was really, really big about any way to fast track what we do or kind of jump to the end too quickly, or trying to get some final dentistry done too early until we have stabilized a patient, whether it's their TMJ or their overall occlusion, will result in a failure for us. It's whether or not we'll see that failure right off the bat or if we'll see it down the road. It's a shortcut, and we try as hard as we can to avoid shortcuts because it's never a shortcut. All the information that we're going to look at for a patient is very clearly outlined in Dr. Dawson's textbook. And if you guys have seen Seminar 1 or Core 1, all this information originally comes from there. So in our complete examination, we're not going to overlook the basic things that we look at for patients: caries, infections, abscesses, these type of things. We're going to look at all that, periodontal conditions. But then we're going to supplement that with looking at the occlusion, looking at the TMJ, looking at the airway to make sure that our patient is overall stable. Start to finish, this exam can take, as I said, about 20 minutes. And it hopefully in some cases, it'll prove that the patient is stable and we don't have to do anything. But unfortunately, a lot of times it will show us that there are some signs of instability. And what I want to talk about today is that we can compartmentalize those, and we can actually put them into play in our offices in not an overwhelming manner for us or for our patients. So one of the things that we're going to try to find out right off the bat is if the patient's stable and if their teeth are working for them, and if they're not. There are some patients who have a very, very odd occlusal scheme, and they don't show any signs of destruction. I don't see them that often, but they do occur. I still can remember a patient from many years ago. He was on sabbatical, or he was on assignment here in the US from England for a couple of years. The guy hit on one tooth. He had a roller coaster occlusal plane, and I can't explain exactly how he got there, but it was working for him, and we basically never had to do any dentistry. He had one area of caries that showed up about a year into when I was seeing him, and we restored the occlusion exactly where it was because it was working. So we don't have to perfect a situation that we don't find is an ideal occlusion if it's supportive for the patient, and if it's working for the patient. But there's a lot of times when an occlusion might look like it's pretty close to good, but it's destroying itself. So that's what we want to find out. Are things working or are things not working? And we can determine this pretty much within 10 minutes of our 20-minute exam. We can figure out if we think that the system's working or not. And if they are working and they need to have some general dental needs, some caries or some basic care, we can go ahead and do that right in their occlusion because things are working enough for them. And then, unfortunately, for some patients, there's situations where things are not working. And sometimes those are not working on a large scale, and sometimes it's just a small scale. But those are going to be our specialty patients where we're going to ask for some additional information to try to figure out if we're going to need to correct the occlusal scheme or improve the occlusal scheme. What are our choices? What are our ways to do it? We're always going to look at, once again, at the basic bacterial sort of issues. We don't want to overlook it when we're looking at occlusion and airway and TMJ related problems. We don't want to start seeing abscesses, or infections start developing because we could have treated something before it got to that point. So we want to make sure we look at all those type of things. But as we go a little further, we're going to look for migration, wear patterns on teeth. We're going to look if they are missing any enamel. We're going to examine the muscles and make sure that they're also relatively flaccid and not hyperfunctioning. And we're going to examine the TMJ. We're going to make sure that there's no clicks or pops, or if there are, we're going to investigate to see what we need to do about them. And then we're always going to ask if they have some aesthetic goals. And in my office, there are patients who are occasionally aesthetically driven, and I have a lot of patients that have no interest in improving their aesthetics. If we end up doing some dentistry, they might want to, make it look as good as we can make it look, but they're not always aesthetically driven. But if they have some aesthetic desires, or we're going to have to change the front teeth in any way, we're going to look at a whole bunch of parameters to make sure that it's going to fit in the face and develop a nice, broad and beautiful smile for the patient that's going to be functional. We're also going to not want to ever forget look at the patient's airway. It turns out that airway trumps pretty much everything else. It's the underlying driving force of a lot of the dysfunction that we see. So we want to make sure that we do an airway screening to see, does a patient suffer from sleep apnea? Are there any reasons why we need to get them off to a physician to help us, manage those type of situations? Because if an airway dysfunction is going on, it can cause a lot of functional damage as well as the patients start parafunctioning without control. So we're going to look at all these different things. We're going to make sure that we ask the patient's history, if they have any history of trauma to their face, if they have any history of clicks or pops. We're going to take a look to see if they have any range of motion issues. We're going to make sure that we use a load testing situation to be able to determine is the TMJ functionally stable? Can it accept a firm amount of force? We in my office use a Doppler very often, actually on every single exam, to listen for the things that might not be evident otherwise, to see if there's any clicks and pops, if there's any instability that we need to address. We're going to palpate all the muscles of mastication, the elevator and depressor muscles, to see are they adequately working, are they overworking. We're going to look for signs of tooth wear, mobility, migration. And if we need, we're going to ask for some additional imaging, whether that's a CBCT and or an MRI. You get a summary that kind of lets us know, does that patient fall into the general category with no signs of instability, or do they fall into that category of signs of instability? And in my office, I'd say probably a decent amount, more than 50%. It's hard to say that it's 75 or 80%. I do have a practice that's getting, over the years, has gotten a little bit known for treating functional issues. But I would still say that we have about a little less than half the patients don't suffer from major occlusal traumas or major occlusal discrepancies or occlusal breakdown. So some of those patients, we're just going to watch and see if they do develop any of those issues. If we do decide that a patient has an airway that is compromised, we'll get them off to the physician to get that studied, get a sleep study or something to let us know, is it acceptable or is it something that needs to be addressed? And once in a while, we'll find out that the patient had no idea there was an issue, but we see signs of that destruction. And we sometimes could potentially save or at least improve their quality of life overall. Once again, we're going to make sure that we do an analysis of the TMJ to make sure that the structures are intact. And if not, what level of breakdown are we noticing? Is this something that we have to go into precision orthotic therapy because we have a truly unstable, deranged condyle disc assembly? Do we have degenerative joint disease, or do we have early lateral pole issues where we might have clicks and pops, which can be managed? Or is it further down the road? So we want to make sure at least we have a diagnosis if somebody's healthy, partially broken down, or basically on the verge of completely breaking down. And I do see that there is a question here, so I'm going to see how centric relation fits into the diagnosis and treatment of TMD and OSA. That's what I was kind of just talking about here. We're going to always want to check to see, do we have a loadable joint? Is the condyle disc assembly intact? If it's not intact, we're going to figure out whether, what's our simplest way to get the joint to be able to be seated. It's a whole detailed lecture that I would implore you guys to read the textbook and watch seminar 1 or core 1 to get all those details. I'll try to touch upon them, but that's a loaded topic. So we are going to either accept that we have a condyle disc assembly that is intact that we can work with, or we're going to treat the TMJ, and that might be a 3 to 6 to 12-month period of time or more, where we're establishing an adapted centric posture, where we have an altered condyle disc assembly, which now can accept loading through either precision or orthotic therapy, combination of meds or other interventions to get the condyle disc assembly to be adapted in a way that it can accept firm loading. Second question here is the direction of treatment is mandibular advancement. We do not advance the mandible unless we have to. No, we are definitely looking to try to be able to seat those joints. Sometimes if the joint has very recently fully displaced, if the disc has come off on the medial aspect and we're pinching on the retrodiscal tissues, we might temporarily use an advancement appliance. If somebody needs their airway opened up and is CPAP intolerant, sometimes we will use an advancement appliance temporarily. But ultimately, we're always going to want to make sure that we have a condyle, even if it's an altered condyle disc assembly, that we can accept firm loading. We do not do any restorative treatment until we can load the joints, even if they are damaged and altered. We want to make sure we stabilize them and we have no changes in our occlusal scheme on an orthotic or whatever we're going to use to monitor that. And once we see no changes for at least a period of 3 to 6 months, then we can go on and see what we need to do to alter the occlusal scheme. If we have an altered condyle disc assembly, we got to do any definitive treatment in the mouth, in my opinion, in my office, I would consider that not standard of care. I would consider that very dangerous. It's a moving target. The occlusion can change rapidly depending on how much the condyle disc assembly is broken down. If we have complete degenerative joint disease, we're bone on bone, and we do not have a good cortication of the condylar head, we might see rapid changes. So we're not going to alter the occlusion until we see some stability in that. And if the airway is also compromised, gold standard still right now is CPAP to get them air so they can breathe and they can be our patients in a few months. If they're CPAP intolerant, then we might go into an advancement appliance if directed by a physician, but that's not where we're going to hold them, and that's not where we're going to build them. We're going to just manage the airway, but then we're going to go ahead and make sure that we can create an occlusal scheme with a seated condyle in the fossa or in the adaptive fossa. All right, so I believe I answered those questions, and so this is how we break down our overall treatment plan. Is we're going to see if the joint is altered, we go ahead and we treat the joint first and or the airway. If there's no signs of overall occlusal muscle breakdown, the TMJ score is relatively negative, then we can go ahead and do some basic dentistry. A lot of our patients are going to fall into the yellow zone. They have loadable joints and maybe early clicking and popping off the lateral pole. So an altered condyle disc assembly, but one that is not fully degenerative joint disease. But they might have some significant signs of instability where we have loose teeth or we have loss of enamel or sore teeth, sensitive teeth. And then we're going to try to see what's our simplest way to correct the occlusion. Okay, and lost the ability to go forward here, so let's do it this way. Okay. So our signs of instability, once again, we're going to look for tooth wear, mobility, migration, spaces that opened up. If we do see some interproximal space in between the teeth, we'll ask a patient, have you always had spaces between the teeth? Because maybe that is where they erupted, or has this been progressive? Sometimes patients will say, no, they used to actually not catch any food. Now they catch food. I'm starting to notice the spaces more. So that means that the problem is progressive and it is actively changing. We're going to look at breakage of restorations, if there's porcelain fractured, if there's fillings that have broken, if there's craze lines, wear facets. We're going to look for abfractions. Abfractions have multiple derivations of where they originate from, but a true abfraction is occlusally derived in its initial breakdown, and then it can break down from corrosive or abrasive wear as well, due to dentifrices and or food and diet can also have corrosive factors on the dentition. But the abfraction itself is very often or most often occlusally driven from the start. We're going to check those muscles out and make sure that we can put several pounds up to 5 pounds of pressure without any discomfort. And we're going to make sure that we have loadable joints. If any of these don't exist, then we have signs of instability, and we have to determine, do we have signs of instability that warrants us intervening? And in my opinion, when I think about occlusal disease and see the problems that we have, a lot of times people are waiting for them to break down further before we treat. The way I correlate that is I go right back to the medical model. How much cancer is enough that we'll watch? I mean, there are very few cancers that we want to watch at all. We want to treat those as early as possible. How much cardiovascular disease is considered okay? I don't know. It's, I guess, an individual clinician determination. But in my opinion, no cardiovascular disease is okay. We want to always intervene as quickly as we can to stop the process. We know that if we leave these processes of cardiovascular disease, cancer, or diabetes, if we let these go on without at least trying to alter or slow down the progression, we're going to see some end-stage situations where they can get pretty bad. So the same thing with occlusal muscle disease and occlusal instabilities or TMJ instabilities. If we just watch and wait, they're not going to correct themselves. They might change. They might have periods of time where they feel some symptoms more, and times when they feel symptoms less. But the disease process is never going to correct itself on its own. So if we recognize that there's a disease process, in my opinion, I always want to try to address it. Now, a patient's not necessarily always going to opt to do something about it right away. But more often than not, if I use the right verbiage and I compel a patient with those concepts of trying to treat something in its earlier stages, we get to do less dentistry overall. If we wait, I mean, we can always treat it. I mean, we can wait till all the teeth are broken down into the pulp chambers. We can always come up with a solution. It just becomes more complex. So I like to treat as early as we can. And so when we look at occlusal disease, we'll see that it is pretty rampant. It is the most common dental disorder, but it also happens to be the most untreated dental disorder because we don't necessarily look often enough to see that it's present. When we start looking with our complete exam and we start looking around the mouth, whether we're going to use photographs or scans and combination of clinical examination, we'll see that if we look, a lot of these problems exist. And once again, going back to what I said earlier, the sooner that we treat something, the better off we are. Centric relation in general, if we have a CRMI slide, or basically a discrepancy between where the joint seats and where the teeth meet. They're two different positions. For some people, there's no issues whatsoever, but for a lot of people, we do have a breakdown. So in this situation, you can see that the left side of this this lever system is the condyle disc assembly in the TM joint, and the joint is fully seated. And you can see that the anterior component, which represents the anterior teeth, we can put a whole bunch of eggs between that system. We can put a lot of pressure and nothing breaks. However, if we have a situation where the joint is not seated together when the joint is not fully seated when the teeth meet, sometimes we can have a situation where we start seeing the breakdown of that system, because the joint will eventually go ahead and seat itself. And then sometimes we'll have an occlusal situation where we'll hit on certain surfaces of the teeth where they can cause fracture, or if we substitute enamel for porcelain, we can see porcelain fracture. So if we don't look for these situations and we do some significant full coverage restorations, all of dentistry could be at risk. So we want to see, is this present? Is it something that needs to be addressed? And if so, we want to make sure that we create a system where we have a seated condyle in the fossa, and we want to make sure that we have a stable occlusal scheme as well. Right, so if we do find that a patient has signs of instability, we're going to ask for some additional information. One day we're just going to ask for digital scans and digital records, and we're on our kind of learning curve to get there. But right now I'm in a hybrid workflow where we'll scan the teeth, we'll print out models, we'll get radiographs as needed. We're going to take a full photographic series, and we're going to take a centric relation bite record and a Facebook transfer, so we can take the information that we're seeing in the patient and we can translate it to our CAS. I just saw that we have another question, so let's see what that is. I have trouble when someone younger comes in with jaw pain and/or popping and clicking, but they have few to no restorations, have had ortho in the past that has aligned their teeth nicely. I have difficulty other than necessary treatment planning, much dentistry. Okay, so I'm going to ask a clarifying question about this question. So when we think about orthodontics, in my opinion, is a full mouth reconstruction. It just happens to be mostly enamel. So when we do orthodontics, in my opinion, we have to correct the occlusal scheme completely. So when you say that the teeth are aligned nicely, does that mean that they have a perfected occlusion? Do we have centric stops in all the teeth? Do we have anterior teeth that are discluding the posterior teeth, or are they symmetrical and they look overall like they have nice arch forms? So until I have that information, it's hard for me to say whether those patients would really be stable or not. I'm going to finalize every single one of my orthodontic treatments, whether I'm doing it or I have a specialist do it. We're going to always follow that up with an equilibration at least a few months after the teeth settle in. So 3 to 6 to 12 months after orthodontics is done, we're equilibrating that dentition one way or the other. If they don't have a lot of few to no restorations, if they have jaw pain and clicking or popping, if you know the anatomy, if you have clicking and popping of your TMJ, it's a significant amount of breakdown. So for me, if I have the lateral pole is not intact and the medial pole is not intact, we're going to do appliance therapy or orthotic therapy, stabilize the joint using our precision orthotic. And then once we see 3 to 6 months of no changes on that, then we're going to go ahead and see what it would take to alter the occlusion. If somebody's got just occlusal muscle issues and early lateral pole breakdown, I still don't allow that to continue on. We want to nip that in the bud, because if we leave that alone, in 5 to 10 to 15 years, we're going to see much more breakdown. So even if a patient has no dentistry or a couple of fillings in their mouth, if they've undergone orthodontic treatment, in my opinion, in my office, we're going to want to perfect that occlusion. If somebody's got a condyle disc assembly that's starting to click and pop and the lateral pole's off, we want to try to stabilize that system before it gets worse. At least that's how I would want to be treated if I were the patient. So that's how I treat my patients. I do not take those things lightly because, as I said earlier, those correlations to cancer and to cardiovascular disease and to diabetes, this is our version of that. So if we let these problems go further, in my opinion, I'm overseeing the breakdown happen. So today I do want to talk about what do we do in those type of situations where we see those relatively early wear patterns. What are some of our options? And I'm going to get to some of that in just a little bit. So hopefully I answered that question properly. Otherwise, we'll get back to it. Okay. All right, so we talked about this. We're gonna, whether this is gonna be in the full digital workflow shortly. We're, as I said in my office, kind of a hybrid workflow. We take our full series of photographs. And then ultimately, if we need to alter the occlusion, we're gonna wanna make sure that we have our functional parameters established, and we wanna make sure that our aesthetic parameters are established as well, if we're gonna do any work on the front teeth. Excuse me. If we're going to do some orthodontics, as if that's one of our treatment options, we're going to also want to make sure that ultimately we get these four goals of aesthetics achieved, as well as the four functional goals achieved. I said before that we never want to get to the end point too fast, but we want to envision what the end's going to look like. When I do my examinations and I see whatever the current status is of a patient I'm examining, I always envision in my head where could or where should it be. If I see signs of breakdown, I envision the 5 requirements of occlusal stability. I envision those front teeth meeting at the same time that the back teeth meet, coincidentally, all at the same time with the seated joint. I envision that the front teeth are going to be in the right location, vertically and horizontally, so that they have a nice looking smile. I envision that those front teeth are going to disbode the posterior teeth, if at all possible. So I'm going to envision all of that before I even get going with a treatment plan. It doesn't mean that we're going to do a tremendous amount of dentistry for somebody, but I'm just having that vision of where it's going to be. And it looks like I have another question, so let's look at that. Why wait 6 to 12 months after ortho, not immediately after the case conclusion? Okay, so my view on this, and I have varying answers that I've heard from other people who do a lot of this. Right after, initially after orthodontic treatment, the ligaments are all very loose, teeth have all just been moving around so much. I find that I'd like to wait before I actually start altering the occlusion. I like to wait at least a couple of months. It's not necessarily, I said earlier, 6 to 12 months. It depends on the situation, depends on the type of orthodontics that was done. We'll hold them in the retainers so that the teeth don't regress. But some people like to do it on day one. I just find that when I was doing that on day one, I felt like I was altering, doing too much coronoplasty. So I like them to settle just a little bit right after the movement. Usually when somebody's done with the orthodontic treatment to when we get post-orthodontic records, it's usually a few weeks anyway, and it's usually a few weeks by the time I've done my analysis and I'm showing a patient what the next step is. So we kind of fall into it just honestly from a scheduling standpoint. So I usually get to the 6 to 8 week mark without thinking twice. So once we're there and once a patient actually schedules to do something about it, usually we're in that couple of month mark. Is it wrong to do it right off the bat? It's hard to say that it's wrong. I just try not to do it too quickly. I know some patients or some practitioners who will do it the day the ortho comes off and they're equilibrating right away. And it's hard to say, once again, that it's wrong. It's just that I don't do it in my office that way. I give it this several weeks where by the time we're actually doing something and altering the occlusion, it's usually a couple of months. All right. Good question, Warren. All right, so we have 4 treatment options to treat any of the conditions that we might see. We have reshaping, which is occlusal equilibration. We do it at the academy. We have a very specific way that we learn to do it. It's not mutilating the teeth. It is finally reshaping them. It is a very, very extremely conservative treatment. I've had it done myself. I can tell you, you can't feel it, aside from feeling like nails on a chalkboard is why I describe to people, just kind of a little bit grating, but there's nothing uncomfortable about it whatsoever. It can be done without anesthesia, without any question. So if we can reshape the dent, when we see signs of instability and we need to alter the occlusion, the simplest option is always reshaping the teeth. Now, when we come up with our treatment plans, if we see significant signs of occlusal wear and anterior teeth that cannot properly disclude the posterior teeth, we're not going to only reshape the teeth. We're probably going to have to do some restorations. If the arch forms are off or the teeth are, we have a very, very poor plane of occlusion. We also have orthodontics available to us. We can restore teeth if and when necessary. And in those more severe cases, we can move segments around. We can reposition bone. So all 4 of these options are available to us for anything that we see as a problem set. And if we need to intervene, I'm always going to look at all 4 of these options and say, what's the most conservative and what would I want to have done if I were this patient? And so that's going to differ from office to office what you'll do. But in my hands, I'm always thinking about what would I want to have done. And once we come up with our plan, we're going to plan it in our mind first. We're going to plan it in wax next. Then we're going to transition that to some sort of plastic. And then ultimately we'll do definitive restorations if and when indicated. I'll tell you, in the cases I'm going to show today, we're probably never going to do any porcelain restorations. It's probably only going to be plastic. But every case is different. And so sometimes I will phase out treatments that are very, very complex that might ultimately need a full mouth reconstruction. We figure out ways to do that very conservatively, do it very stable for the patient, fiscally responsible, where we can kind of spread out some finances if and when necessary. And we can accelerate that treatment time and do it faster if a patient wants to do it faster. But we're not going to force people to do full mouth reconstructions. We're just going to treat the mouth fully. We're going to treat the occlusal scheme fully. We're going to treat the entire dentition, but we don't necessarily do full mouth reconstructions. We just address the whole full mouth. So in the end, as I said earlier, the way I think about this, I want to do as little as possible to get the job done. I can always do more dentistry if I need to later. It's very hard to reverse your dentistry. It's very hard to undo a crown. However, you can always do a crown later on. So let's look at Allison. So Allison comes to me originally because she was having headaches and she felt like she had lost her bite. And the dentist that was seeing her for her routine examinations and cleanings said, oh, she's starting to wear out her teeth and she's sore everywhere, and I don't know what to do. So she referred him to me, thinking that she had a TMJ problem. It turns out that she did not have a TMJ problem. She had an occlusal muscle problem and a tooth wear problem. So it turned out that her occlusal scheme was what the issue was. It was not a TMJ issue. A lot of times people will feel like they have a TMJ issue because they have sore muscles, or the teeth are sensitive, or the bite's off and they're grinding their teeth. But it turns out that their TMJs could be stable. And that's why we do the examination to determine if it is stable. And in Allison's case, her TMJ was completely stable. So we were able to figure out a plan that addressed her occlusal muscle symptoms and kept her TMJ intact and treat her. So let's look into her case a little bit further. She right off the bat said, I've got insurance and I've got to work within my insurance. Time was an issue for her because she's a teacher. So we had to figure out ways to keep appointment times relatively short. And we once again analyzed her condyle disc assembly, did a full TMJ occlusal evaluation. We did a comprehensive exam and records, and turned out her joints were completely fine. So we then, I'm going to fast track through this because this is our core 2 class where we talk about all the, core 3, where we talk about the details on how we plan this out. But we're going to come up with a plan that is as minimally invasive as possible to alter and correct that occlusal scheme when we see signs of breakdown. So I want to show you some of her photos here so you can see slightly omega shaped arch forms developing. You can see the narrowness in the posterior. You can see how the anterior is starting to flare out a little bit. Also, you can see the spaces that have developed, which were not there apparently. And you can see the loss of enamel on multiple of her posterior teeth. So her primary concern was that she had lost her bite. She felt like any little restorations that she was getting done were breaking down. She noticed that her teeth were moving around and her muscles were sore and she was getting headaches. So once again, we determined that her joint was actually absolutely fine, but it turned out her occlusion, she failed all 5 requirements of occlusal stability. So she did not have centric stops on all her teeth. She had a CRMI slide. She had an anterior guidance that was not, she did not have anterior guidance. She had group function bilaterally with, I believe, a balancing interference as well. So her occlusal scheme was not working for her, and her dentition was starting to destroy itself. So when we analyzed everything, I did not like the arch forms. When I see arch forms like this, when basically the tongue doesn't have room and it's starting to come over the occlusal surfaces of the teeth, I'm already automatically thinking, I don't like this arch form. But I don't like this arch form, I'm automatically thinking that maybe expanding the arch will improve the overall situation. And it turns out, as we asked her some questions, she did not have daytime sleepiness. Her Epworth sleepy scale was pretty good, but she was starting to develop a little bit of snoring. So we did send her off for a consult, and her OSA was absolutely fine, or she had no events, but she was probably headed down that road. So I'll show you some more photos of her. You can see she's starting to lose the enamel, and she's pretty young. I want to say she's early 30s at this point. You can see the early enamel wear on the incisors. You might see it a little bit more clearly on these photos. But you can see the arch forms off. You can see the loss of the enamel on the occlusal surfaces, and you're starting to see these little loss of enamel in the anterior. Now, if you're doing a routine exam on somebody, and Allison's your patient, if you're not looking for these signs of instability, you might overlook this. She's got fractions that are developing. You can see in the posterior here, she's getting a loss of attachment. She's sensitive in all of those areas. And she's just thinking originally that she's brushing too hard and that she lost her bite and she's grinding her teeth. So we just gather all that information, and we always remember that we have 4 treatment options available to us. And so as we analyzed her situation, orthodontics popped up numerous times in how it can improve her overall situation. And so we proposed a treatment plan that involved Invisalign to expand her arch forms, get the anterior relationship a little bit improved, and she accepted that. So we did, I would think it was 8 to 12 months of Invisalign. Held her at that point for about somewhere in that 1 to 2 month mark before we got our post-ortho records. And then we did the second part of our plan. We planned all this out in the beginning. I want to say that we're not kind of changing things up a whole bunch as we go along. When we did the initial analysis, we realized that she had loss of enamel in multiple areas. She had fractions that had developed. She was starting to lose enamel in the anterior dentition. So we had already planned all that. So we said phase 1 was going to be orthodontics. Phase 2 was going to be an additive reductive equilibration. So reshaping some of the teeth and adding to a whole bunch of them. And so this is how she ended up at the end of the orthodontic phase. And these are some other angles. And then we do the same workup again, just to perfect and to dial in exactly what we're going to do for her. And in her case, this is where we ended up. So you can see there's occlusal composites in the posterior. We've rebuilt the anatomy on the canines and the incisors. This is a very, very conservative additive reductive equilibration. So sum total of work here, we probably did about, let's see, probably more than 10 composites, when you include the buccal class 5s, when you include the occlusals and the incisal edges, and the lingual incisals on the canine. So it's a decent amount of composites that we did as part of the equilibration. So we did an additive reductive. We added to the areas where they were deficient, and we reduced where we could in a planned way, post-orthodontically, to give her back a stable occlusion. So at this point, at the end of this phase, she has achieved the 5 requirements of occlusal stability. So we have seated condyles in the fossa. We have teeth that are coincident. They all meet at the same time, equal intensity stops all around the mouth. And we've got an anterior guidance that very, very shallowly discludes the posterior dentition. So Allison's been done for several years now. I've seen her for a couple of follow-ups just to make sure that she's good. All the sensitivity has completely gone away. She has not chipped any respirations, and she's extremely comfortable, and she stopped snoring. So it's hard for me to say that I treated her airway. I think I improved her arch forms. I improved her upper airway resistance, and I treated her occlusion, but happened to just make her breathe a little bit better as well. All right, so there's a question here. Let's go ahead and see what that is. No, Allison does not suffer from OSA. Allison only had snoring just start to develop. She went for a screening with her physician. I don't know what type of sleep study she had done, and she had virtually no events, so she did not have it. And she had tongue scalloping. You're absolutely right. And that was another reason so she has indicators that lead me to believe that she could end up having airway dysfunction. She medically got cleared from it. That being said, I know where this goes if I leave it alone. So that's why I corrected the arch forms. That's why I knew that that was part of the solution. So I want to treat her completely. And as I'm treating her completely, I'm correcting the arch forms and correcting the occlusion. So yes, and she does not bite her tongue, and she does not have a scalloped tongue as much as she did before, because I put the teeth more where they're supposed to be. All right, so let's go to Leanne. So Leanne comes to me with early clicking joints, and she was uncomfortable. She's a hairdresser, and she's working over top of the patient all day long, and it was getting worse and worse. Referred by her dentist as well, who didn't feel comfortable treating her. He knew that the occlusion was all over the place, and he didn't even know where to start. He felt like it was going to be too much of an undertaking for him to do. And so I evaluated her, and the clicking, so she did start breaking down her TMJ, but it was at the very early aspect. It was just on the lateral pole. So she had the ability to accept firm loading on the condyle. The disc assembly was partially altered, but it was still able to accept firm loading. So in this case, I put her on some medicines. I put her on a deprogrammer. She came back the next visit, and all her symptoms had gone away. So then we started discussing, all right, what are potential options? I did a complete exam and records on her, and came up with an option, which, what do you think we saw? Well, at this point, the joint is healthy. We've determined. We weren't sure in the very beginning, but look at these arch forms and look at the teeth out of place. She's got, and she said that it had changed. She had orthodontics as a child. She never was equilibrated. And she said she did wear her retainers for a while and then stopped wearing retainers. So she goes, yeah, that kind of looked like how I did in the beginning. And so she remembers having kind of, she called it the Bugs Bunny look. I don't know if it's quite that bad, but obviously she's got pretty dominant centrals and almost a non-existent laterals. So let's look at these questions. Two more popped up. Oh, same ones. Okay, so let's get those out. All right, so this is our arch form. And so what do you think we do? We have 4 treatment options available to us. I don't like these arch forms. I don't like the class 2 div 2. I know that that's going to suffer further breakdown. You can also see that her tongue's filling in the space. And she also has felt like she's lost her bite. So got her symptom-free with a deprogrammer and meds. It continued to be able to load the joint. And so We also prescribed orthodontic treatment. We used Invisalign to round out the archworms. Her case took a little bit longer than Allison's because it's a little bit more complex. And let's go this way. But you can see how severely crowded she was, and left alone, could she be okay? Well, she was already starting to show signs of breakdown. So I'd say if we left her alone for another 5 years, she would just break down further, and then we would start seeing breakage of the teeth, or other structures would be breaking down. So we have our 4 treatment options, and this is her post Invisalign. So much better rounded out arch forms. You can see she now has room for her tongue. The anterior relationship has been improved. We've got a nice incisal plane. We've got good overall, nice wide rounded arch forms, and we've got the anterior teeth in the right location. As the earlier question said, does this mean that these teeth are reasonably aligned? Is this where we stop? No. We talked about it in the beginning. The first phase was going to be orthodontics. The second phase was going to be an additive reductive equilibration. In her case, she was only deficient in enamel on her canines. So we did an additive reductive equilibration, mostly reductive, a little bit of additive on the canines. Now we have questions that popped up. Can you please elaborate which medications? Okay, yeah, so when I have occlusal muscle dysfunction, there's a couple of routes we go. Sometimes the deep program is all we need, but sometimes I'll give them a muscle relaxant for about a week usage. I very often will see these patients as an initial consultation for a reasonably short visit. And so I bring them back a week or 2 later, and I prescribe 2 medications. One is skeletal muscle relaxant, cyclobenzaprine 5 milligrams. I ask her to take it about an hour before bedtime. And I do meloxicam, anti-inflammatory. It's Mobic, and I prescribe 7.5 milligrams. And I ask her to take it with breakfast and dinner for 5 days, take a break for a day or 2 so you don't cause yourself an ulcer, and take it for another 5 days. By that point, I've seen her as a follow-up, see how everything's doing. She's completely symptom-free. We take her off meds, and we go ahead and we start planning the treatment. So those are the meds that I like to use. Those work well in my hands. And so that's the post-Invisalign result. And then we're going to finish this up with an additive reductive equilibration. All right. And this is how she finishes up. So you can see very, very subtle bonding on the canines. And then we reshape the posteriors. Now, the 5 requirements of occlusal stability have met. We've got the teeth in the right overall location. She's got centric stops on every single tooth around her mouth. The anterior teeth have adequately discluded the posterior teeth in every excursive or every motion of the mandible. All right, so very, very, very conservative. So when I look at cases like this, I mean, these patients are in most general offices. It's a significant amount of dentistry to do orthodontics if you're going to do it. It's a significant amount of dentistry to do in like Allison's case, where we did a number of restorations. But we did it really, really conservatively. When people see these type of how these patients started out, a lot of times they're looking at, well, I mean, we've lost enamel here. We got to crown this tooth. We got to onlay this tooth. I use composite resin bonding as an interim restoration on so many cases. And it enables me to stabilize an occlusion, test an occlusion. And then ultimately, if we ever need to upgrade that to an indirect restoration, we can. I'll just tell you that a lot of times I don't have to. So like in Allison's case, and in oh my God, I forgot her name. But in this case also, we did not have to do a whole lot of reshaping. We added and we did very, very fine equilibration to get the occlusal scheme exactly as we needed it to. So ultimately, in both of these cases, I kind of never forget this. If I were these patients, what would I want to have done? It's the most conservative dentistry that I can imagine, to have some teeth moved around, a little bit of reshaping of sun, and adding to others. Just so you know, these plans are not they still do have a significant cost. But if these had, I have so many cases where they're a little bit worse than this, so that people think that they need crowns on all these teeth. I do the same exact technique where we round out arch forms if they need to with Invisalign. We do an additive reductive equilibration to stabilize occlusal scheme. From a cost standpoint, all of that said and done, most of my plans, depending on how many teeth are involved and how complex the orthodontics is going to be, these cases run somewhere between $8,000 to $15,000. So I mean, it's a significant amount. In Allison's case, I want to say she topped that at around 12,000 for everything. I want to say that with Leanne, it was probably a little bit less because it was less restorative. These cases don't have to, break the bank. Some of them end up, as I said, as low as $8,000 because, I mean, it's just an Invisalign, a little additive reductive equilibration to try to be very fair with the patient. I also know that we're going to end up doing virtually no other dentistry for these people. So I feel very strongly that we can charge significantly for what we're doing because we're just stabilizing their systems so well. It ends up being a really good comfort zone for me when I talk about even more complicated cases than this, that this is stuff that can fall into a lot of people's budgets. If these plans that are shy of $20,000, like up to 15, 60, I presented one today, 16,000. It's a very, very, very similar, actually, I think 17, a little bit more complex, but similar ideas. We're going to take about two plus years to get all of it done. It ends up being able to be done. And if somebody can't do it, we spread it out a little bit more. We do, we'll wait a little longer between the Invisalign phase and the additive reductive equilibration. So these are plans that can be done in almost any office, and it's not like you have to present a full mouth rehabilitation. My point is that we're trying to do as little dentistry as we need to do to get the job done, but we can always add more dentistry if needed. If we do something like this and we ultimately want to improve the aesthetics so much, we can come back and we can do very, very conservative contact lens veneers. We can upgrade some of the composite restorations to an indirect porcelain restoration. There's always the opportunity to do those type of things. But in some of these cases, when function is a little bit more important for somebody than aesthetics, we can get a functionally aesthetic result very, very conservative. And then if they want to do more than that, we can always do more than that. But I'm always starting with that end in mind. All right. So I see that there's another question. Let's see if I answered it. And oh, okay, I already answered that. So it was the same one. And I just want to end my presentation itself on the guy who got me here was Dr. Dawson, who has just had me have that concept of examine your patient. Your patient deserves a complete examination. Everybody he felt deserved a complete examination. So I always perform a complete examination on every patient. Now, whether or not we do the treatment right away or we're going to elect to do it in a year or two, that's always up to a patient. I always try to instruct patients to understand that the earlier we intervene, the better off we are, but it's up to them when they want to intervene. If they want to wait for something to break, or if they want to wait till they get more symptomatic, that's their choice. And I'm here for them regardless. What I love is the fact that when we discuss these type of things, when we talk about doing ethically what's right for the patient and trying to do as little dentistry for somebody in their lifetime, it makes sense to a lot of people. And for the ones it doesn't make sense to right away, the first time that I have suggested that something could happen, the first thing that breaks, they come back and they say, okay, I know we talked about this before. What do we got to do? I'm ready now. So everybody's different in their form of readiness. But so what I do want to mention for those of you guys who are on here who have not gone through the curriculum, and this is your first introduction to our philosophy, I just want to let you know that we teach all of the things that got us here in these cases. We teach it in our curriculum. And so we have Core 2 coming up in New Jersey, and I teach that, and I'll teach you the entire exam process. Core 3 is where we teach you, the treatment planning process. But they're running a special right now, which I've never heard of. It's absolutely amazing. If you sign up for Core 2, you get Core 1 basically at no cost. So I'm not sure, Dylan, if you want to give any additional information or if you want to chime in about that. But basically, I've never heard of anything like this. And it's where you get all the information. Basically, you learn how to plan any case that comes to your office. You can, in a very, very predictable way, stabilize your patients and do it in as complex or as practical a way as you can. And I believe that these cases, a lot of them can be very, very practical and very affordable for patients and can be done in pretty much every general dental office.